My name is Dr. Mark Taubert. I'm a palliative care consultant, and these are some top tips for people who are going to engage in sensitive CPR and DNACPR discussions. It's quite important to say that these are my ideas and my approaches, and they certainly might not work for everyone. And I think it's especially important to say that everyone needs to adopt their own personal style when engaging and starting these very pertinent discussions with people. It's about sharing and involving patients and their loved ones in this very important decision. In fact, sharing and involving is what the new All Wales Do Not Attempt CPR policy is called. Familiarise yourself with the form, policy and patient information leaflet before you hold any such discussions. Don't focus too much on the form during the consult. Focus on the person in front of you. Listen and explore. They may have really strong views on CPR already. Find out what they are. Talk this through with healthcare professional colleagues and the senior medical person overlooking the care. The best person to hold these discussions is someone who knows the patient and family already. Don't make CPR discussions part of a formulaic process or tick box exercise. See it as the most important discussion, potentially, that this person you are facing has ever had to have. Get the setting right if you can. A quiet room, comfort, privacy, and try to ensure, if the patient agrees, that a relative or friend is there too. Explain what CPR actually is, and that the success rate is low in frail patients with palliative and life-limiting conditions. Explain that CPR involves physical force that aims to restart a heart that has already stopped working, aiming to reanimate. Reassure patients that all other treatments like intravenous fluids, antibiotics, blood products, radiotherapy, chemotherapy, dialysis are still all on offer. If patients do want to know the risks of CPR, sensitively explain risks such as permanent brain damage, rib fractures, internal bleeds, coma, and the real chance of a death that may be considered by many as quite undignified. Start by asking the patient or their family whether they have already specified an advanced plan or advanced decision. They may ask you, what is an advanced plan or what is an advanced decision? And you can explain to them that advanced care plans involve making decisions in advance of needing a healthcare intervention, specifying that you would want it or you would not want it. I often start by asking patients whether there are any treatments that they wouldn't want. I explain that we would routinely offer intravenous medicines, blood, chemotherapy, dialysis, etc., but also ask whether they would actually want these. I use a treatment ladder approach in my palliative patients, and the higher up the ladder, the more invasive the treatment, with CPR being right at the top of the ladder. I go up this metaphorical ladder with the patient and their family, and often they agree with most treatments like intravenous antibiotics for severe pneumonias or intravenous blood for an anemia. But they often don't want the treatment at the top, which is CPR. However, they are often reassured by my telling them that they will be offered all the other rungs on this treatment ladder. Ensure with the utmost effort that the patient has a full opportunity to engage in this important communication with you, and make sure visual and hearing deficits, for example, are no bar to this. Ensure that the patient is able to understand the ins and outs of CPR, and make sure they are not confused or unable to retain information. Always make sure they have the mental competence to have these discussions. Always try to involve relatives and loved ones in proxy in these conversations. Ask for permission to get relatives involved. Try to make them part of this very important discussion. Feel your way into and through the discussion. Use checking questions like, are you feeling ready to talk about this? Or do you want me to stop talking about this particular topic? Do this frequently so the patient can go at their own pace. Sometimes talking about the end of life and dying can be seen as distasteful, but most of my patients have a lot to say on the topic. Asking anyone how they would want to be and how they'd see themselves in their final moments is truly personal. And I've never actually heard anyone think of CPR when they're envisaging death and dying. Ask them sensitively how they would see their final moments. Most won't mention CPR. And you can comment on this, for instance, by saying, I noticed that you didn't mention any big medical interventions like chest compressions or tubes in the airways there. I assume that would not be something that you'd want. If you want a bit more information about all these different aspects of discussing CPR with patients, then it is worth you going to this website, which has a number of resources. It has, for instance, the sharing and involving information leaflet for patients and their carers, and it also has the policy document on it that you can read and find out some more information on.